C'est officiel, le FMF 2020 sera virtuel. Du 4 au 7 novembre, participez au plus grand congrès de médecine de famille au Canada. Le FMF offrira plus d'une centaine de séances et ateliers de formation de grande qualité fondés sur les données probantes avec un horaire flexible. Le contenu restera affiché en ligne pendant 30 jours. Cette année, nous vous réservons d'incroyables plénières. Dr Carole Herbert parlera de la nécessité de trouver de nouvelles façons d'intégrer les données probantes dans la pratique, malgré le rythme effréné du monde d'aujourd'hui. Le conférencier professionnel Stéphane Megan s'attaquera à des sujets difficiles pour inspirer en nous la résilience et l'excellence au moment où nous en avons le plus de besoin. Dr Yona He donnera ses réflexions sur l'année 2020 qu'elle voit comme le moment de prendre des risques dans la pratique. Durant les 4 jours de l'événement, vous aurez l'occasion d'explorer un hall d'exposition virtuel pour vous informer sur les innovations et les outils en médecine de famille. Et ce n'est pas tout. Vous pourrez échanger avec vos pairs dans notre espace de réseautage en ligne et discuter avec eux des questions importantes. Les tarifs pour participer au FMF seront beaucoup réduits cette année. Vous pourrez vous inscrire dès maintenant au fmf.cfpc.ca. Suivez-nous sur Facebook, Twitter et Instagram.
It's official. FMF 2020 is going virtual. Join us for Canada's largest family medicine conference, November 4th to the 7th. FMF will offer more than 100 top-quality, evidence-based sessions and workshops on a flexible schedule. And they'll be available online for 30 days. This year, we're including some incredible keynote speakers such as Dr. Carol Herbert, who will examine how we have to find new ways to incorporate evidence into practice in our fast-paced world. Professional speaker Stephen Megan will tackle tough issues and inspire resiliency and greatness when we need it most. Dr. Yona He, who will share her thoughts on how 2020 is a year of practicing dangerously. Throughout the 4-day event, you'll also be able to explore the virtual exhibit hall to learn about innovations and tools in family medicine. Don't forget to connect with your peers in our online networking space to discuss important topics. FMF is being offered at greatly reduced rates this year, and registration is now open at fmf.cfpc.ca. Connect with us on Facebook, Twitter, and Instagram.
Hello, everyone, and welcome to Practical Talks for Family Docs. I'm Janice Harvey, and I'm your host for today's clinical live webinar series brought to you by the College of Family Physicians of Canada. I'm very happy today to be joined by Dr. Allan Grill, who will give us an overview presentation on the practical approach to treating patients with chronic kidney disease. But before I introduce Allan, there are a couple of quick housekeeping items that I do want to review first. We welcome questions from you as viewers. So if you're watching us today on our YouTube channel, we welcome you to post your questions at any time in the chat box, which you'll find to the right side of your screen. If you don't see that, you may just need to reduce your view. If you're watching us on Facebook, you'll see the chat forum either on the right side of your viewing screen or below, depending on the device that you're using. It also, as with all of our webinars, this is certified for 1 Main Pro Plus credit. And to claim your credit, all you need to do is to click on a link that you'll see appear in the chat box near the end of the hour. That link will be live until the end of day on Sunday. And all you need to do is click on the link and answer a few short evaluation questions, and you'll be able to claim your credit. If at any time you wish to view any of our archived webinars on the CFPC website, you are eligible to claim a non-certified Main Pro Plus credit for any of those sessions. So now it's my pleasure to introduce our speaker today. This is Dr. Allan Grill. It's an especial pleasure for me because Allan is a colleague of mine at the CFPC, where we are both physician advisors in the Professional Development and Practice Support Division. Allan did his undergraduate medical training and his residency through the University of Toronto, and then went on to Harvard University to get his master's in public health. Currently, Allan is an associate professor through the Department of Family and Community Medicine at U of T, and he is the chief of family medicine at Markham Stouffville Hospital, as well as the lead physician of the Markham Family Health Team. Today, Allan brings a breadth and wealth of information on chronic kidney disease, because from 2012 to 2018, Allan was the provincial medical lead of primary care for Cancer Care Ontario's Renal Network. And he co-developed a fantastic resource called the Kidneywise Clinical Toolkit, which is a wonderful resource for family physicians dealing with patients in their offices with chronic kidney disease. And it's now my pleasure to turn the presentation over to you, Allan.
Thanks so much, Janice, and good morning, everybody. It's great to be here. I hope everybody is feeling well, enjoying the summer, and staying safe given the COVID-19 pandemic. So today we're going to shift base away from the pandemic, and we're going to talk about chronic kidney disease. And I titled this talk "Tips for the Busy Family Physician" because by the end of this lunch hour, or depending on where you are across Canada, I want to make sure you get some practical tips on how to manage chronic kidney disease. And I think that at the end of this presentation, hopefully we'll get there. So in terms of my presenter disclosures and conflicts of interest, you can see the list of my financial relationships here. I'll just tell you that none of these organizations are for-profit. They're all not-for-profit. And I don't have any relationship whatsoever with the pharmaceutical industry. If you're interested in tweeting or being on social media, I mean, most of you are watching on Facebook and YouTube at this time, but feel free to go to my Twitter handle, which is @Allan_K_GrillMD. The Twitter handle for the College of Family Physicians of Canada is @FamPhysCan, and you can feel free to put some comments there if you like. And if you see my picture at the bottom of the screen, you'll know that you found me. Okay. So today's learning objectives. So there's 3 of them. We're going to identify a practical clinical algorithm that can be implemented in primary care practice to help manage patients with chronic kidney disease. We're going to differentiate patients with increased risk of advanced chronic kidney disease using the kidney failure risk equation, which is a new concept to most family physicians. And we're going to interpret blood pressure treatment targets and the use of SGLT2 inhibitors for patients with chronic kidney disease. So chronic renal failure, for all those people that are still using it, is actually an outdated term. And it's been replaced by chronic kidney disease, which I'll refer to as CKD throughout the presentation. Acute renal failure is also an outdated term. And the term I'll be using to refer to that is actually called acute kidney injury, or AKI. And we'll get into that as well. And isn't it better to talk about renal success as opposed to renal failure? All right, that's about as funny as I think I'm going to get today. So in terms of the prevalence of chronic kidney disease, so 10% of North Americans have chronic kidney disease, and that's about 26 million people. And so what you're thinking of is, by introducing this topic, is this automatically going to create a burden to my practice? And the answer is no. I mean, most of the people that have chronic kidney disease are actually older individuals over 65, but only 3% of all of the patients that you're going to manage in your practice with chronic kidney disease are actually going to progress to what we call end-stage renal disease or end-stage kidney disease. So the good news is that most of these patients you can manage on your own in your family medicine practice at the primary care level. Okay. So why should chronic kidney disease be important to primary care? Well, 90% of the CKD cases you're going to see in your office are actually at low risk of progression, and they can be followed by a primary care provider. So on this call, we've got family physicians, we've probably got some nurse practitioners, and I would argue that in long-term care, 100% of the patients that you see with chronic kidney disease can be managed without specialist intervention, assuming that they aren't tied to a nephrologist when they become your patient. Early identification and treatment of chronic kidney disease can prevent or delay progression to end-stage renal disease, which is really important because end-stage renal disease is associated with comorbidities as well as mortality. And if you do medication reviews on a regular basis with your patients, especially in long-term care, you can actually prevent what we call acute kidney injury. So that's when you have situations where you have a patient on a medication and because of their chronic kidney disease, either the dose is too high or they shouldn't be on that medication at all. And I'll be going over some references to help you out with this later on in the presentation. Chronic kidney disease is associated with cardiovascular disease risk. And so because we're already good at managing that, especially in patients with diabetes and those with known disease like coronary artery disease or congestive heart failure, you should apply the same principles to patients with CKD. And finally, if you do identify patients that are at high risk of progression to more advanced stages of chronic kidney disease, and I will get into what to look out for to make those decisions, these patients should really be referred early to nephrology. The question is why? Well, the answer is because if these patients end up needing renal replacement therapy, that being dialysis or transplant, it's very important that they get the counseling needed early. They need things like vascular access, and all of these things are done much better if they're done early and not under stress. There's nothing worse for a patient that ends up getting advanced chronic kidney disease. We find it at the last minute. They end up in the emergency department. They need emergency dialysis. It's much better to plan this in advance. And that's one of the reasons why I refer to nephrology. And I will be going over some other reasons why nephrologists can help us out with regards to kidney problems later on in today's presentation. So this is just a page to show you the algorithm that Janice mentioned earlier. So I worked on something called Kidneywise, which is an algorithm that you can go to. The website is here. It's www.kidneywise.ca. And I'm going to walk you through this algorithm today during the talk. But this is something that was created by the Ontario Renal Network, where I used to work as the provincial primary care lead. And you can look this up after the presentation if you want to look at it in more detail. The other thing I just want to mention is that the Kidneywise Clinical Toolkit was endorsed by the College of Family Physicians of Canada. And I promise you that they didn't just endorse it because I happen to work there. This is a completely separate endorsement process where once the Kidneywise Toolkit was created and published and it was put out there, our team put an application into the CFPC to get it endorsed, and it was endorsed. So I just want you to know that even though the algorithm was a provincial project, it really does apply across Canada. It applies nationally, and the CFPC recognized that. And this is just a copy of part of the letter that I got in December 2019 when it was endorsed by the college. Okay, so the toolkit actually has three parts. There's a clinical algorithm, and I'll go through that. It helps identify who's at high risk for chronic kidney disease, how to actually make the diagnosis, and how to manage these patients, and when to know when to refer. And those are the four key steps when you're talking about identification and management. There's also an evidence summary that offers further clinical detail that you can read at your leisure. It's a two-page document that you can find on the Ontario Renal Network website that I gave earlier. And it just goes into some of the evidence behind how we came to the decisions that we did with regards to the toolkit. And finally, there's actually an outpatient nephrology referral form that I will show at the end. It actually gives guidance on which patients should be referred to. You can increase the instructions are there. We use it in our office as well, and it should be accepted by most nephrologists, depending on the region that you work in. So in terms of the guidelines that we referenced when we put this together, there were four. So the Kidney Disease Improving Global Outcomes, or KDIGO, they're an international organization that basically produces CKD guidelines for physicians. They haven't updated this one since 2012, so we are expecting a new one soon. We also looked at the Hypertension Canada guidelines, which even though they came out in, I think, 2018, there's been updates since, and so we incorporated the 2020 updates into this talk as well as the algorithm. There's the Canadian Cardiovascular Society Dyslipidemia guidelines. Again, those are still 2012. And there's the Diabetes Canada Clinical Practice Guidelines from 2018, which actually has a chapter on chronic kidney disease. And Kidneywise was actually referenced in that chapter. So why am I telling you all this? So one, we tried to keep this as evidence-based as possible, but two, because we didn't want you to have to go look at a bunch of different guidelines when you were looking at our algorithm. We tried to keep it consistent with the various guidelines that touch upon chronic kidney disease and the various comorbidities. And hopefully you'll feel that we did a good job consistently as I go through this presentation. Okay, so the first thing you have to do is figure out who is at high risk for chronic kidney disease. What we don't want is we don't want you to screen or test everybody, and neither does the Canadian Society of Nephrology, so they would agree with this. So if a patient has hypertension, diabetes, or cardiovascular disease, then you definitely want to identify these patients and test them or screen them for chronic kidney disease. And I'll talk about what to order in a moment. In the 2018 update to the algorithm, we added FINIM, which stands for First Nations, Inuit, and Métis. Anyone who belongs to this population that's over 18 is actually at high risk of chronic kidney disease. It used to be thought that because of their high prevalence of diabetes and hypertension in this population, that's what put them at high risk. But in fact, it's now felt that there's actually a genetic component, and anyone in this population that's over 18 should be identified as a high-risk patient for chronic kidney disease. It was also in 2020, the Ontario Renal Network added a first-degree relative with chronic kidney disease. They're also considered high risk and they should be screened. The one key point though here is that you really shouldn't screen a patient if their life expectancy is under 10 years. So if you have a frail elderly patient that maybe you pick up as a new patient in your practice, or if you do long-term care, and you happen to identify them as having chronic kidney disease, and maybe it wasn't identified in the past, that's fine, but I wouldn't start fishing for it. Most of the time, you're gonna have an EGFR or creatinine level on these patients for various reasons that I'll get into, but I wouldn't necessarily screen them for CKD. If they made it that far and you don't think their life expectancy is beyond 10 years, then this algorithm really doesn't apply to that population. Okay, so what should you order to make the diagnosis? Well, it's very easy. You need to order a creatinine level, which usually comes with an EGFR. It's a serum blood test. In some hospital labs, you have to ask for the EGFR specifically, but in most community labs across Canada, if you order a creatinine, you'll get an EGFR, and that measures kidney function. The second test you have to order is a urine for ACR, which stands for albumin to creatinine ratio. This is a measure of kidney damage or injury, and it's when protein gets excreted in the urine. And that's all you need to do. 2 tests, very simple. It's on the lab rec and you can find it. I do not recommend you order a 24-hour urine collection. Why? Because it doesn't really add much. The urine ACR will tell you about kidney damage, and it will give you a general sense of whether they're spilling protein or they have albuminuria. And secondly, most of the time when you have to explain a 24-hour urine to a patient, sometimes it's not explained properly. Other times the patient doesn't get all the instructions, they do it wrong. Then what ends up happening is you get a result, you don't know how to interpret it. And ultimately, if that patient gets referred to a nephrologist, that nephrologist is likely going to reorder the test, and then your patient is going to get very mad at you that you ordered the test before and they have to go through the same thing again. So at the primary care level, I would not recommend a 24-hour urine collection when you're trying to identify patients with chronic kidney disease. The other key point to the slide is that never screen a patient at high risk for CKD who might have an acute intercurrent illness. So if you think they're dehydrated from a gastroenteritis, or they've just run a marathon and happen to come to your office the next day, you want to order this test when they're sort of in their steady state. And the reason why is because sometimes you can mistake a chronic kidney disease picture with what we call an acute kidney injury picture. So if you have an acute kidney injury and you think it's CKD, you'll label a patient with an unnecessary diagnosis. And a lot of the AKI situations we see in primary care are actually reversible, and they need a different workup. And I'll get into that in a moment. But for screening CKD, make sure the patient is feeling well and is asymptomatic at the time. Okay, so if you order the EGFR and the urine ACR and the results come back abnormal, what do? So assuming the patient is not sick, if the EGFR is less than 60, that is considered abnormal, and the patient might have chronic kidney disease. If the urine ACR is greater or equal to 3, that also is considered abnormal, and that patient might have CKD. So what do? Well, it's very simple. If one or both of these is abnormal, you take a deep breath, and then you remind yourself to retest in 3 months. you can't make a diagnosis of kidney disease until the patient has an abnormality in one or both of these categories for at least 3 months. There's a couple caveats here. Number one, if the urine ACR originally is abnormal, and then you repeat it again in 3 months and it's normal, you kind of need the tiebreaker test. And so usually you'll repeat it 2 to 3 weeks after that. But for the eGFR, if the first one is abnormal and the second one is normal, they don't have CKD. And I'll walk you through that. But the bottom line is one test result is not enough to make the diagnosis. And CKD is defined as a persistent abnormality for at least 3 months with these 2 abnormal results. Okay, now what happens when you order the first test and you get a result back that just doesn't sit well with you? It almost feels like something else is going on. So there's a clinical concern. Well, a clinical concern by how we defined it is usually when you have a rapid decline from a previous eGFR. So if you've never had an eGFR before, then obviously that doesn't help you. But if you've had one previously for whatever reason, and all of a sudden the one you do now is very different, that should give you a clinical concern. Or if you just get an unexpected eGFR or urine ACR result. So if the eGFR is really low or the urine ACR is really high and you weren't expecting that, that should give you clinical concern. So usually in those situations, we don't recommend waiting 3 months to repeat the test. Usually we tell you to repeat it maybe 2 weeks later, so something sooner. And while you're thinking about it, I want you to think about all the things that might be a reversible cause for the result you got, because maybe this is an acute kidney injury. So things like, are the patient taking over-the-counter NSAIDs, non-steroidal anti-inflammatory drugs, and they're just not telling you about it? Is the patient on a herbal remedy and that's affecting their ability of their kidneys to work? Did they just have a diagnostic imaging test and contrast dye was used and maybe they were on the tipping point of CKD and now they have an AKI? Are they obstructed? So if it's a male, do they have a large prostate? Are they in urinary retention? Do they have volume depletion? Are they dehydrated due to an illness? Which again, you shouldn't be screening if they're ill. And some patients, especially older ones who are on diuretics for various medical conditions, might actually be taking them wrong, or maybe they're on too high of a dose and therefore their volume depleted, and that's put them into an acute kidney injury. So basically, you should consider all of these things that might be reversible when you get one of those results that gives you clinical concern. And remember, this also applies to any other time you, let's say, might be ordering an eGFR or a serum creatinine. So for instance, for those of us that do long-term care, we're often asked to do an annual serum creatinine EGFR level because when flu season starts and we want to dose Tamiflu in situations where we pick up an influenza outbreak early enough, the dose of that Tamiflu is dependent on knowing what the renal function is. And again, if you're doing a medical workup for something else and you order a serum creatinine and you get an abnormal result, always think about reversible causes at the time because it's not always due to CKD. The other point I want to make about this slide is that we don't recommend a renal ultrasound as part of a CKD screening workup. So if you're just screening for CKD because of a high-risk patient based on the list I went over a couple of slides ago, renal ultrasound just doesn't really add much to the picture. But if you think there's a reversible cause based on an abnormal result, and that will help you make a diagnosis, then by all means do the renal ultrasound. So maybe you'll pick up hydronephrosis secondary to BPH, and that's going to help you cinch the diagnosis, right? It would be a post-renal obstruction. So then you would order an ultrasound. But just to order an ultrasound because you're screening for CKD, we don't recommend it. There's a lot of inter-rater reliability, and it really doesn't add much to the picture at the primary care level. Okay, so once you do the first set of tests, if the first set of tests is abnormal, one or both of them, and then you don't have a clinical concern, and then you repeat them 3 months later, here are the following possibilities. It's kind of like a choose your own adventure book that we used to read as kids. So number one, if the eGFR, the second one, is now greater than 60, which is normal, and or the eGFR is less than 3, which is normal, that patient does not have CKD. So don't label them with the diagnosis. The question is, what do you do after that? Well, we recommend that you screen patients with diabetes at least once a year because of their high risk of chronic kidney disease. And for everybody else, you kind of do it as clinical circumstances dictate. Now, before the pandemic, I would have said that I tend to screen my high-risk patients for CKD at their wellness visits, or what some people call periodic health exams. Whether we're going to do periodic health exams the same way moving forward is up for debate. And I recommend you go back to the COVID-19 webinar that we had on that topic a few months ago to take a look at that. But even if you're doing periodic health exams virtually, either during the pandemic or moving forward, it's very easy to retest a patient for chronic kidney disease. Just send them a lab rec, tell them to get the EGFR and urine ACR done, and then you can look at it. So once a year for people with diabetes, and then a little bit less frequently for people with other high-risk categories. And again, tying it to the periodic health exam makes sense. But don't label them with the diagnosis if they don't have it. Okay, now here's an extreme example. Let's say the second result comes back abnormal, but it's very abnormal. So the EGFR is less than 30, and remember, 60 is the cutoff in isolation for being normal. Or the EGFR is greater than 60. And remember, the cutoff for abnormality is greater than 3. In this situation, the patient has chronic kidney disease because it's been persistent for 3 months. We actually recommend that these patients be seen by a nephrologist. And the reason why is because you're starting to move into stage 4 chronic kidney disease, and the high proteinuria puts them at high risk of progression, which means they're likely going to see a nephrologist sooner rather than later. So these patients, even when you make the diagnosis 3 months later, some people have to see a nephrologist right away. Now, while you're sending that referral, there's a couple other tests you should be ordering. So you should order a urine routine and microscopy, and this is done to look for red blood cell casts. So you want to make sure there's not some inflammatory condition like glomerulonephritis or IgA nephropathy or some sort of renal vasculitis that you might have missed that's not that common in primary care. Secondly, you should order electrolytes as a baseline because some patients with CKD can have electrolyte abnormalities like hyperkalemia or hypotassium. Secondly, we did recommend that since you're sending them to a nephrologist and they're going to order this anyway, you should get a CBC to see if these patients, which again are more advanced CKD, are already showing signs of anemia, and if their calcium profile is abnormal. So because the kidney plays a role in metabolism, bone metabolism, you want to look at their calcium level, their phosphate level, and their albumin level. And remember, you need an albumin level to know whether the serum calcium needs an adjustment. But the bottom line here is that even if you refer your patient with more advanced chronic kidney disease, please don't lose your relationship with them. Continue to follow them. There's a lot you can do with the management. We're not just handing it off. This should be sort of like a co-management shared care model with nephrology. Okay, this is the most important category in terms of the choose your own adventure after 3 months that you should pay attention to, because this is where the majority of people that you're going to diagnose CKD are going to fall. So this is where the second EGFR comes back abnormal, but it's between 30 and 59, okay? And the second ACR, which also comes back abnormal, is between 3 and 60. These patients have CKD because the second result is abnormal. And basically the workup for them is a little bit different than the previous slide. All you want to do here is check the urine RNM for the same reasons I mentioned earlier, and you want to check their electrolytes. So the question is, what do you do now? Like, how do you manage them? How often do you follow them? Well, if you look at this screen, which is put together by KDIGO, I call this the heat map. This is a complicated way of looking at how much you see the patient for follow-up, depending on their urine ACR level and their EGFR level. And I don't know about you, but this is not family medicine friendly. It's too complicated, and you're not going to be referring to this. And I would recommend we leave this heat map for the specialist and the nephrologist. For family physicians, here's what we recommend. If you diagnose them with CKD and they're in stage 3A to 3B, which is where their EGFR is between 30 and 59, and or the ACR is between 3 and 60, you basically want to follow these EGFRs and urine ACRs for progression. We recommend you do the test every 6 months from when the diagnosis is made. And if the EGFR is stable for at least 2 years, you can then switch these two tests to do it annually. So again, every 6 months after the diagnosis, assuming they're still in this window, until their EGFR is stable for 2 years, then you just do it once a year. Now, the question is, while you're doing this, what do you look out for? That's what I'm going to cover next. But before I do so, I just want to put in a bit of a plug for something called the kidney failure risk equation, which is one of the things you're going to use moving forward as you're monitoring your patient for progression of chronic kidney disease. So the KFRE basically uses lab information to calculate the risk of kidney disease progression beyond for patients that you diagnose that are in stages 3 to 5. In other words, what are the chances of somebody you've diagnosed with CKD progressing to the point where they're going to need renal replacement therapy, either dialysis or transplant? It's 4 variables: age, sex, EGFR, and urine ACR. So you have all this information at your fingertips, and you can just put it into either this website, which will give you its own calculator, or this website. And you'll get these slides off of the CFPC website. The QXMD is a calculator where you can work this out, and it will give you the 5-year risk, the percentage over 5 years, whether they're going to go to end-stage renal disease. And I'm going to give you what the percentage is in a moment. So here's what you're doing when you're following your patient with CKD every 6 months for at least 2 years, and then if their EGFR is stable, every year after that. If you find any of these red flags, you should refer to nephrology. So we've already covered 2 of them. EGFR less than 30 should get a nephrology consult. The urine ACR greater than 60 should also get a nephro consult. The one that's hard to remember is if the EGFR is less than 45 and the patient has a decline of 5 mils per minute over 6 months. In other words, somebody has an EGFR of 44 when you make the diagnosis, and then 6 months later it goes down to, let's say, 39. That means that they're at high risk of progression. And we changed this criteria. It used to be if you were under 60 EGFR and then had the 5 mil decline, that was a reason for referral, but it is now 45 because we're more concerned about patients closer to the end of progression to end-stage renal disease. And finally, the 5-year KFRE, if that is greater than 5%, they should be referred to nephrology. The nice thing about the KFRE is it's a really good thing to give patients reassurance, because if their 5-year KFRE is not greater than 5%, then they can actually be reassured that in the next 5 years, they're likely not going to need renal replacement therapy. You're still looking for the other things on this slide, but the KFRE is a great thing that you can show patients at the bedside or in your office to give them reassurance. Okay, so let's talk about management. I'm not going to spend too much time on lifestyle modification and smoking cessation. I think you're all very good at that. I think we're all very good at determining lipid management for primary prevention, and you can use Framingham. The only difference is for patients with CKD, there is evidence to show that they have a higher risk of progression to cardiovascular disease. And so one of the differences is that if their 10-year Framingham is greater than 10%, it's actually recommended that you have a conversation with them to treat them with a statin. The rest of the things here are pretty straightforward and you should be used to them already. But the criteria for CKD in terms of statin management is a little bit less lenient than any other patient who you're dealing with for primary prevention of CVD. The other thing I'll mention is that for diabetes management, I would just refer to the Diabetes Canada guidelines because we don't have enough time to talk about them here, but a lot of patients have diabetes as well as CKD. Okay, other things you can do. Well, in my opinion, no patient with CKD should be using NSAIDs unless it's absolutely necessary. They need them because they're in so much pain for a chronic pain condition and they just can't live without them. Otherwise, I would avoid NSAIDs at all costs. And if your patient is going to be on NSAIDs and has CKD, make sure you're monitoring their renal function very closely because it is toxic to the kidney. If you're sending a patient for a DI test and they need contrast, make sure the radiologist is aware of what their EGFR is. Most of the time, we have to let them know. But for those of us that work in rural settings where you don't have a radiologist on site and you're ordering some of these tests on your own, just make sure you're checking the EGFR. And sometimes you have to hydrate the patients or take them off diuretics before they go for the test. And the sick day medication list, which is SADMANS, which I will go over, is another thing that's important. You want to stop certain medications in patients that have CKD when they're sick to avoid an acute kidney injury. This is the SADMANS acronym. I won't read it out. You can see it here on the screen, and Diabetes Canada came up with this. Remember that if you have a patient with CKD, to always adjust their dose of medication. Take the extra 30 seconds, use whatever app that you use to look up the proper dose in patients with CKD, including medications that should be avoided in CKD. And just to let you know, most of the time you can either use their EGFR or if you want to use Cockcroft-Gault for their creatinine clearance to figure out what the right dose is, It's only in extreme circumstances where you have a very thin, frail patient or a very obese patient where you have to make sure that those two results correlate. But most of the time in the outpatient setting, either use the eGFR or the creatinine clearance, and most of the apps or the resources that you use will allow you to reference both. Okay, so here's the blood pressure treatment target, and it's summarized nicely here. So if you have a patient with chronic kidney disease that does not have diabetes, and they have hypertension, you're actually trying to get their systolic blood pressure down to 120. Now, this is based on the SPRINT trial criteria, and I will go over something to summarize that in a moment. If you have CKD and diabetes and you have hypertension, then your systolic blood pressure treatment target is less than 130 systolic. Now, what happens if you have CKD, but you don't have diabetes, you still have hypertension, but then you have some of these criteria that were excluded from the SPRINT trial: frail elderly, long-term care, polypharmacy, history of stroke, limited life expectancy. In those circumstances, Hypertension Canada and our algorithm says that the systolic blood pressure target should be less than 140. So again, that 120 target is for the high-risk patients from the SPRINT trial, which included patients with CKD. It did not include diabetes patients. And you have to have a conversation with your patient, because some patients don't want to go as low as 120, nor can they tolerate it. But this is consistent with Hypertension Canada and our algorithm. So again, all of this data is based on using an automated cuff in your office. If you're using a manual cuff, none of this applies. And the high-risk patients, just to show you, this is the list from the SPRINT trial, and you'll notice chronic kidney disease was on that list. And again, you'll notice here, Hypertension Canada talks about 120 if you're a high-risk patient and you don't have any of the exclusion criteria from the SPRINT trial. Okay, so do you want to go slow or do you want to sprint? You decide. All right, that's, again, another piece of humor I tried to incorporate in today's talk. So here's another quick slide about using ACE inhibitors and ARBs. And again, you don't have to memorize this now, but if you have a patient with CKD and diabetes, and their blood pressure is greater than 130/80, you can use, and they need pharmacotherapy, you can use whatever medication you want based on Hypertension Canada. But if that same patient with hypertension has a urine ACR greater than 3, you should actually even if they don't have hypertension, you should actually put them on an ACE or an ARB in order to minimize progression of CKD, but make sure you watch for orthostatic hypotension. If their baseline blood pressure is already low, then the risks of putting them on an ACE or ARB, even with a urine ACR that's high, outweigh the benefits. If you have a patient with CKD that does not have diabetes and they have hypertension, again, to treat their blood pressure, use whatever you like from Hypertension Canada. But if their urine ACR is greater than 30 and they have CKD and they have hypertension, use an ACE or an ARB as the first-line treatment for their hypertension. It just so happens that in those patients with the heavier proteinuria, it's better to use the ACE or ARB to treat both their blood pressure so you can minimize renal damage. Okay, I know that that's a lot of information, but these slides will be available to you. You can put them up in your office and follow them. Just remember that any ACE or ARB or even a diuretic that gets started, the lights and creatinine should be tested 2 weeks later. And you can expect up to a 25% decrease in your eGFR or increase in your serum creatinine that is still safe. If it's above 25% or you're concerned about the change, stop the drug, speak to your local nephrologist because you want to make sure that the patient doesn't need a workup for renal artery stenosis. Okay, so very quickly, I want to go through CKD and diabetes and the role of SGLT2 inhibitors. And I'm mentioning this briefly because there's a lot of information coming down the pipeline here. You'll notice that in this chart, and this is from CMAJ, there were 3 trials, EMPA-REG, CANVAS, and DECLARE, that looked at MACE, which is major adverse cardiovascular events, in patients with diabetes who were put on an SGLT2 inhibitor. And it turns out that these patients benefited when they were on these drugs in terms of that outcome, okay? And that's why most of us in Diabetes Canada is recommending that if you have a patient with diabetes who's on metformin and isn't well controlled that has cardiovascular disease, you can consider an SGLT2 medication. But there was an interesting trial called the Credence trial, which you'll see on the right, And it included a lot of people with chronic kidney disease. So 60% had an eGFR under 60, and almost 100% had heavy proteinuria. And they looked at renal outcomes as primary outcomes. They looked at doubling of the creatinine, end-stage renal disease, as well as cardiovascular or renal death. And it turns out that patients in this trial who had diabetes and CKD had benefit in that primary prevention category. And here's just a quick slide to show you. I wouldn't pay too much attention on anything but credence because they weren't primary outcomes there, but it did favor the SGLT2 inhibitors. Now you have to remember there are some side effects with these drugs, and I've listed them here. So if you're going to prescribe them, make sure you have a conversation with your patient. The other thing that's important is I've already mentioned the first bullet about poor glycemic control with diabetes and cardiovascular disease. The question is, are we going to start doing the same thing for patients who aren't well controlled with diabetes and CKD? And what if they already are well controlled? Are we going to recommend these drugs? So right now, and again, I just mentioned the SADMANs again, that these are part of that category. So right now, Diabetes Canada, I've already mentioned this, basically focuses on patients that have diabetes and cardiovascular disease to put patients on SGLT2 inhibitors, but they have a caveat to say it will also likely benefit the patient if they have CKD on top of that. The Europeans are a little bit more aggressive. They're saying that you should consider the SGLT2 in any patient with diabetes and CKD who is poorly controlled on metformin, or if they're well controlled on metformin, but they're on another drug, like a second drug that's helping them with their glycemic control, you should consider switching it for an SGLT2 inhibitor if they have CKD. And the Americans are the most aggressive because they're saying that put any patient with diabetes and CKD on an SGLT2, regardless of hemoglobin A1C. So like I said, we haven't moved in that direction yet in Canada. There will be updates shortly because there's a bunch of other trials looking at this. There are some other trials that are also going to look at CKD patients alone. So again, more data to follow, but I just wanted to give you a quick update. Okay, we're going to finish up very quickly so we can get to the Q&A. This is the example of the outpatient nephrology referral form. You can download it from the Ontario Renal Network website, and you can use it when you're sending referrals to nephrologists. They should accept it without a problem. And just to point out from this slide, because we've covered everything on the left, but on the right, just remember, nephrologists are happy to see patients that have resistant or secondary hypertension, people that have kidney stones, people that have electrolyte abnormalities. Like if you think it's something that you can get help with, don't hesitate to refer. You might learn something and it'll benefit the patient. Okay, but again, for CKD purposes, you can manage most people on your own and you don't actually have to refer unless they meet these criteria. This is just a slide to show you that the journey of chronic kidney disease starts at the primary care level, but for some progresses even to the level of renal replacement therapy, and some patients want to go through conservative therapy. They don't want transplant, they don't want dialysis. So please remember to have goals of care discussions with your patients. We did a webinar on advanced care planning that's on our website at the CFPC that's still up to date. Take a look at it, but don't stop caring for your patient even if they enter the nephrology world of medicine. You're still their physician, you still need to immunize them, you still need to do cancer screening. The nephrologists are not going to do that. Okay, this is just an article I wrote for Canadian Family Physician. If you haven't read it, it was published in 2018. It will go over everything I've mentioned in this talk, plus a bit more detail. And it was one of the top 10 downloads in 2018. So I think it's a decent article. Please take a look, send me feedback if you like. For any of you who do the Foundation for Medical Practice Education problem-based small group learning, you have to pay for it, but it is industry-free of bias, and you get accreditation from the college. There's a brand new CKD module that came out. I was one of the reviewers for it. I think it's quite good. So maybe review it if you're already part of FMPE, or if you're joining this year, check it out. Let me know what you think. So take-home points so we can get to the Q&A. Remember that you should only test patients for CKD if they're at high risk. Don't do it when they're acutely ill, and don't do it in elderly patients with a limited life expectancy. The only two tests you need are an eGFR and a urine ACR. Most patients can be managed in primary care based on all the things we talked about today. Only refer based on the appropriate criteria. Hopefully the Kidneywise clinical toolkit will make life easier for you and empower you to be comfortable with managing these patients. And finally, the two major updates to the toolkit, which were covered with the blood pressure treatment targets and the KFRE. And with that, I think I'll hand it back over to Janice to see if there's any live Q&A questions.
Thanks very much, Allan. That was fantastic. You broke that down and made it very straightforward, very simplified, and very practical. And I know I'm speaking on behalf of everyone, but I'm sure we all feel a lot better about seeing patients and having a much clearer direction on how to handle patients that we're concerned about, and basically how to screen. I'm going to give folks a minute or two to post any of their questions into the chat box. But I will, in that time, I will mention our upcoming webinars. So our next one is on September the 15th. And Dr. Mike Allen and Dr. Nick Pinlott will be discussing the top 10 articles from the CFP journal. And then on September 29th, we'll be joined by Dr. Anna Wilkinson, who is going to do a presentation called Demystifying Breast Cancer. And she'll be going through a whole approach on symptoms, on diagnosis, treatment, and survivorship care. So please make sure that you tune in for that. And if you haven't already seen it, you will be shortly seeing the link to claim your MainPro Plus credit for this webinar. And the link will be open, as I mentioned earlier, to end of day on Sunday. So Allan, a question from Melissa. Should we order a renal ultrasound if a patient has CKD severe enough to warrant a referral to a nephrologist? Or should we just do the blood work and then the referral?
It's a great question. So the answer is we don't recommend you ordering the renal ultrasound. And the reason why I say that is because if you're convinced they have CKD and it's a patient that meets criteria to refer to nephrology, so, someone that's high risk of progression already, the reason why I don't order a renal ultrasound is because I worry that, and this is not a knock against nephrologists, I worry that if the nephrologist doesn't like the center that I'm affiliated with in terms of how the ultrasound was done, or they don't like the community lab that did the ultrasound, they're going to reorder it, and it becomes an inconvenience for the patient. So I would prefer to just send them to nephrology. I highly doubt, I have not had a situation where a nephrologist has not accepted one of my referrals where I've painted a nice picture for them based on the Kidneywise algorithm and said, well, I'm not going to see them until you get a renal ultrasound. That's never happened to me. And if they choose to do the renal ultrasound, which inevitably they tend to do, I'd rather them choose the site that they like, the radiology group that interprets it for them, and then the patient only has to go through it once. So I'm really trying, we really tried to make this easier for providers and easier on patients. And that's why, unless you're suspicious of an acute kidney injury, I would not be ordering a renal ultrasound as part of my CKD workup.
Great, thank you very much for that. Very straightforward. Another question, this is from Jeff. How sufficient are e-consults for some of the recommendations the recommended consultations with nephrologists?
It's a great question, and it's a great plug for e-consult. So I would say that, again, I work in Ontario, and I'm very fortunate to have access to e-consult. It's a great tool, and for people that work in my province, if you haven't connected yet with the e-consult group and how to set it up, you should definitely look into it. So nephrology issues related to primary care, I would say, is like they were designed for e-consult, because if you think about it, most of what we talked about today, they don't necessarily need an urgent in-person referral, right? Like if you think somebody is at high risk of progression and you send a referral, I'm not convinced that the nephrologist is going to need to see them the next day. If you're starting to manage them, you've ordered the right additional tests, they're not declining rapidly in front of your eyes, that patient's probably going to get in within, 4 to 6 weeks, let's say, depending on the wait list. And so if that's the case, sometimes you can do an e-consult to get the same answer, and you often get it way quicker. So again, in Ontario, most of the e-consults I sent, including nephrology, you get them back usually within 48 hours. Like, people are really good about that. And often it can save the patient an in-person referral. So there's nothing better than being able to call your patient back 2 or 3 days after you've seen them in the office and say, hey, I spoke to the specialist that we talked about. I got some great information. You don't have to go see them. Number one, they'll be really impressed that you spoke to the specialist like within 2 or 3 days. And secondly, they don't have to take time out of their busy day to go see that specialist down the road. So the e-consult will not only give you quick answers to things, but it will also let you know whether an in-person referral is actually necessary. And if it is, how the patient to wait. So I do it all the time. The other thing I would tell you is that if you have a good relationship with your local nephrologist, send them an email. I mean, if you have secure email, there are some provinces that allow you to bill for those types of conversations. So if financial constraints are a barrier, we can get around that. But either e-consult officially so it can go in their chart, or a secure email or phone call with a local nephrologist, I recommend either of those as opposed to just sending off a referral and having it sit somewhere. If you're concerned, try to get an answer as quick as possible. And I'm a big fan of e-consult.
And in this day and age with COVID and people's hesitation to send patients, or patients' hesitation to go into an acute care setting or a hospital setting, and e-consults, it sounds like makes a lot of sense as well, just from that standpoint. All right, and another question we have from Patricia. Can you comment on starting sodium bicarb for a high BUN? Also managing volume intake and whether it makes a difference to the eGFR.
So the short answer is I can't. I'll be honest. That's out of my scope of practice / scope of knowledge. I would say that the best way to have that question answered is when you check the slide deck, there's actually, even though I don't work for the Ontario Renal Network anymore, they're still accepting questions. It's Kidneywise at renalnetwork.on.ca, Kidneywise at renalnetwork.on.ca. I would fire that question over to them. You'll get a good answer. Or it's another question that you could ask as an e-consult if it relates to one of your patients. But to be honest, I don't have the knowledge to be able to answer that question related to today's talk.
Okay, thanks for that and the information and that point. The next question is with respect to diabetics. Is an ACE better than an ARB, or does it really matter?
Yeah, that's a great question, and I've gotten that question before. So the answer is it doesn't matter. So if we go back in time, one of the biggest beefs, so this is Allan Grill speaking completely independently. One of the biggest beefs I had was when people were choosing ARBs over ACE inhibitors simply because somebody got the bug into their ear. I would say that for the purposes of today's talk, when you're treating hypertension or you're treating a high urine ACR in patients with CKD and diabetes, it doesn't matter which one you pick. And in fact, there was a time where it was better to pick an ACE inhibitor because they were cheaper. And we know that, we always have to look at it from the patient's perspective. We want to make sure they get the best treatment sort of at the least cost to respect our publicly funded healthcare system. Nowadays, most of the ARBs have gone generic, and so it's less of an issue. So if you have more comfort level because you happen to be using ARBs more historically, and it's not costing the patient any different, then I think you can choose either one. My general practice is you can, at this day and age, if the cost is the same, choose either one. If you're going to choose an ACE inhibitor first, always look out for that cough, right? I've seen this a lot in my practice where I put someone on an ACE inhibitor and then they come back with this dry cough. It's not going away. And sometimes I start working them up with a dry cough and I've forgotten that I'd started them on the ACE inhibitor. And sometimes changing that from the ACE inhibitor to an ARB eliminates that cough completely and they do well. There are some situations where we can get a cough on an ARB, but it's much less common. So that's why during this talk, you'll see me use the term ACE inhibitor / ARB, because I don't have a preference with regards to the material for today's webinar.
But I'm sure the patients have preference for side effects too. So that's a very good point. All right, we're going to have a couple of questions now with respect to blood pressure. So someone asked, what is the rationale for lower blood pressure targets in CKD patients without diabetes versus those that have diabetes?
Yep. So again, and I'm sorry I went through that material so quickly, but if you look up the SPRINT trial, and it was published in the New England Journal of Medicine, you could Google it. The SPRINT trial looked at patients. They wanted to see whether more aggressive blood pressure targets had a benefit with regards to cardiovascular outcomes for certain high-risk patients, right? And there were 4 categories of those patients. There were any patient over age 75, any patient with CKD that had an EGFR between 20 and 60, right? So they weren't talking EGFRs below 20. Any patient that had known cardiovascular disease, and then any patient, I believe, with a 10-year Framingham risk of 15% or higher. So they took those patients and they randomized them to more aggressive blood pressure targets. So a systolic target of 120 in one arm, less than 120 or around 120. And then in the other arm, less than 140. And they looked at these cardiovascular outcomes. And it turns out that for those high-risk patients, their cardiovascular outcomes were better with more aggressive treatment. Now, there's a bunch of caveats that you have to take into account with that trial. Number one, it's a randomized controlled trial. It's always a little bit different than real-life experience. Secondly, those patients might have been very keen to get their blood pressure down. That's not always the case in your real-life office. And finally, the most important is they excluded a bunch of people. So diabetics or people with diabetes were excluded. So anyone with CKD and diabetes, you can't apply the aggressive blood pressure treatment target to them because if you had diabetes, you weren't in the trial. Same with people that live in long-term care, have dementia, have orthostatic hypotension at baseline, are on more than 5 drugs. So polypharmacy was another big issue. So what I wanted to present today is to show you that our algorithm was based on Hypertension Canada's interpretation of the SPRINT trial, which I think was fair, but you have to take into account all of the exclusion criteria, and you have to have a conversation with your patient. You have to say to them, look, I have your blood pressure under 140 right now. I think that that's reasonable control. But if I can get you even lower towards 120, you might have cardiovascular benefit based on this trial. But we have to monitor you closely. I've got to make sure you're not going to fall. I've got to look at all these things. And if your patient is game and they meet criteria, I would give it a try. But if the patient is reluctant or they aren't interested in getting lower because they're worried about falls and those things, you make your best clinical judgment. But to completely dismiss the SPRINT trial, especially considering Hypertension Canada supported the results, would be unfair to this group. So that's the difference when we talk about CKD alone and hypertension and CKD with diabetes and hypertension. The diabetes patients were not included in the SPRINT trial, and they were not considered one of those high-risk categories.
Okay, thank you very much. That's so important for people to know, and that's one of the reasons that when any of us are reading a study, we really need to look very closely at the inclusion and exclusion criteria. I'm going to end with the final question here, again related a little bit to what we were talking about with blood pressure, ACE, and ARBs. Is there a risk of the blood pressure dropping to a point where it's going to affect renal perfusion when you're considering starting an ACE or an ARB?
That is a great question, and I'm really glad that came up. So first of all, when we're talking about patients, so we're talking about patients with CKD today. So that's our baseline. So now add hypertension to that. So remember that anytime you treat a patient for hypertension, you obviously have to monitor their blood pressure when you're treating them. So you don't want that. You don't want to keep going low, 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 right? We just talked about the 120 versus the 140. So depending on where you fall in that window. But you don't want to make their blood pressure too low so that you will actually affect perfusion of the kidneys and other organs. So that's number one. Number two, one of the things in our algorithm that was in one of the slides, but I didn't mention, you've got to be very careful if somebody's diastolic blood pressure at baseline is less than 60 or if it goes below 60. So there is some evidence to show that if you knock their diastolic down too much or their baseline diastolic is very low compared to their systolic, you might actually be doing them a disservice. And there's some patients that are high risk of stroke when that happens. So we were very specific in our algorithm, and Hypertension Canada mentions this too, that you've got to be careful with the diastolic going too low. Like don't just focus on the systolic. But at the end of the day, you want their blood pressure to be within the treatment target range that Hypertension Canada supports. You want to watch the diastolic. And for those patients that you're putting on an ACE or an ARB that have nothing to do with hypertension, so the patients with CKD and diabetes who do not have high blood pressure, but they have an elevated urine ACR, always make sure if you're starting an ACE or ARB that you're not knocking their baseline blood pressure down even further. That's going to put them at risk of falls or, as my colleague mentioned, low target organ perfusion. So, these are some of the things we have to think about. Algorithms try to simplify them, but if your gut is telling you that their blood pressure is going too low, cut back on the drug, because often people are overtreated as opposed to being a problem with undertreatment.
Thank you, Allan, very much. That was not only, as I mentioned, a great practical and simplified approach to managing these somewhat overwhelming and difficult patients, but the answers to your questions were just really informative and fantastic. So from all of us that are viewing, it's my pleasure to thank you for giving us such a great presentation. And to all the viewers, just a reminder that if you wish to claim your certified credit, you just click on the link in the chat box. It'll be live until Sunday, and that's where the evaluation form will be. And don't forget to sign up for our FMF virtual conference this year. The link is at fmf.cfpc.ca. And if you register before September 12th, then you're eligible for the early bird rate. And it's going to be 4 days of great sessions, virtual networking, posters, and we hope to see you all there. And we hope to see you next time at Practical Talks for Family Docs. Goodbye, everyone.